The study that I was presented at ASCO as a poster on behalf of my colleagues that were all a part of the REACH-PC study was a study that was looking at end-of-life outcomes and communication amongst what is called the REACH-PC study. The REACH-PC study was a study of a very large study that was PCORI funded of 22 centers across the country that enrolled 1,250 patients and then many caregivers as well on a trial that was looking at the delivery of palliative care within the context of a new diagnosis of advanced non-small cell lung cancer. And these patients were randomized between in-person palliative care visits monthly with the palliative care team and their centers versus telehealth palliative care visits. And the primary outcomes of this study were published last year in JAMA and presented as a plenary at ASCO last year. And the poster that we had this year was a secondary analysis of this study. The primary analysis last year showed that there was equivalence in quality of life in these two arms, really highlighting that telehealth delivery of palliative care was what we think of as fairly equivalent to in-person visits. And that is really important, in particular now with the COVID pandemic, and then that now we're on the other side of that, but we're all still living in this world of being able to consider telehealth delivery. But we don't have a lot of trials actually comparing outcomes of patients who got telehealth versus in person. So this study really gave us some of that data in a way before we realized before its time. I mean, the study started before COVID, before this was such a relevant question, but ended up being something that was really fundamentally important. And so the first most important, or not, the primary outcome was looking at quality of life. So that was what was published last year. This poster looked at end of life care delivery, as well as patient-clinician communication. And although the thresholds for statistical equivalence were not met, when you look at this numerically, there are very similar outcomes in terms of patient-clinician communication about end-of-life preferences. And then there were also very similar outcomes in terms of hospice length of stay, as well as various kinds of healthcare utilization near the end of life, such as ER visits and hospitalizations, as well as intravenous chemotherapy, advanced care planning, those types of outcomes. And so I think that importantly, when we're thinking about integrating a palliative care team, those are some of the outcomes that have, in prior studies, shown to be beneficial by incorporating a palliative care team. And so showing that those appear to be equivalent in telehealth versus in-person visits is really important, sort of secondary piece to continue to add to the evidence that telehealth is just as beneficial. This is particularly important because not everybody has access to a palliative care team. And so thinking about how we are able to deliver palliative care to people more than just those who are coming in, but also being able to access other populations that may not have such access is really ultimately very important. We have had several studies now that have shown the benefit of integrating palliative care. And so I think that that to me is very clear. I think that just because there's research showing that this is beneficial doesn't mean that it's happening. There is a lot, the true intervention that was done here was monthly visits with palliative care, which may be quite an intensive intervention when you think about sort of resources holistically. They also, Dr. Temmel and her colleagues also had another publication last year that's called STEPPED PC, I believe is the acronym, that looked at a slightly a slightly attenuated version of of palliative care intervention to see do you really need monthly visits, or is there another way you can deliver a palliative care intervention but still have the same outcomes? And that study also was positive in the slightly different intervention. So I think that is one aspect that's important. And then the other piece is where there's been a lot of work in is what is actually happening. What is truly facilitating or moderating the benefits of these palliative care models? And does it always have to be a palliative care team, or are there other people who could deliver this? Are there other ways to serve patients and their families in a way that we are through these interventions, but that don't necessarily require palliative care clinicians to do all of the interventions? Because the other piece of all of this is that there are not enough palliative care clinicians for every patient and family to be seeing this team throughout all of their care with advanced cancers. So I do think thinking about how we approach this from a limited resource perspective is also critical to the future studies.